Hey everyone, my name is Dr. Galatia Strong. I'm a physical therapist who got 100% on my NPTE, and this led me to co-found SPT with Me, which is an NPTE prep platform. If you enjoy what you see here, check out sptwithme.com when you're studying for the NPTE. Now onto what you're actually here for, let's talk about Parkinson's disease. Even without diving into the specifics about the pathophysiology behind Parkinson's disease, these should be the first things that you think about if someone were to mention it. So let's go through a few of these. So it is a movement disorder. When you think about seeing a person who has this, you're going to expect to see shuffling gait. Your patient is stooped over. They have resting tremors, meaning that the tremors are occurring when they are not moving at all. So think about their hand shaking or something similar. With the brain, this occurs due to something happening within the brain. Obviously, we'll go more into depth, but just understand as of this point, something's going on with the brain. Other things to think about are cognitive changes. So dual tasking is going to be more challenging for these people. The sound of a person's voice is much quieter as this disease progresses. Now, with all this, yes, it is great to know. However, if you're going to be a physical therapist, you do need to know Parkinson's disease into much more depth. It's a very hefty topic. However, let's see if we can clear some things up and make it a tiny bit more simple. So here are the things that are important for you to know as a physical therapist. We'll be going to more depth with each and every one of these. However, let's just go through it briefly right now. So the first thing is the basal ganglia. This is a cluster of nuclei that are spread both within the cerebral hemispheres and within the brainstem. There are 5 components of the basal ganglia. However, clearly here I've just listed the substantia nigra. It's just one of them. And the reason I've only listed this one is because this is the part of the basal ganglia that is associated with the reason of why Parkinson's disease presents the way that it does. So one of the primary jobs of the substantia nigra is to produce dopamine, which is a neurotransmitter. But in Parkinson's disease, this substantia nigra does not create enough dopamine. And this effect is exactly why Parkinsonian symptoms exist. Secondly, the indirect and direct pathways. These two pathways are involved with the communication of things that go on within the basal ganglia and communication going to the thalamus, to the cortex, to and from, okay? So they're both pathways that involve a large part of the brain, and they are ultimately altogether what drives movement. Now, because of a lack of dopamine, these pathways don't work optimally, which will result in the movement impairments that we see. Next, we have levodopa. This is the drug that you should absolutely associate with Parkinson's disease. Lastly, the cardinal signs of Parkinson's disease are these 3. So it's resting tremors, meaning that tremors are happening when the patient's not moving. Rigidity speaks for itself. And bradykinesia, which means that movement occurs very slowly. Then there are some other hallmark signs. This includes shuffling gait that I've mentioned before. Again, they're hunched over, they're stooped over, and these people tend to lose balance forwards. So let's take a look at the table first. As I've mentioned before, there are 5 components to the basal ganglia. This includes the caudate, the putamen, globus pallidus, subthalamic nucleus, and substantia nigra. These are not all in the same area. The caudate, putamen, and globus pallidus are closer together, and these are all located within the cerebrum, deep to it, while the substantia nigra is in the midbrain, and the subthalamic nucleus is ventral, so it's anterior to the thalamus. I do have other pictures to show you, however, I don't really want to put too many pictures on one slide, so let's just start off with this one. So what I do want you to notice is that the basal ganglia is a 3-dimensional structure. As you can see, it protrudes out laterally a little bit, then it goes anterior to posterior, loops around, right? So just keep this in mind, because often when we are instructed about how to learn the basal ganglia, we are shown cross sections of the brain. And of course, yes, it is helpful to visualize, especially when we talk about the pathways. But this image in particular is something that we don't see often. It's a lot bigger of a structure than we think, right? It's 3-dimensional. It is not 2-dimensional in which a cross-section would suggest, okay? So I'm going to show you what I'm talking about in the upcoming slides. So first example is here, right? We have a cross-section of the brain. So we're looking laterally on a person, so we see the brainstem, the corpus callosum, etc. And like I mentioned before, the substantia nigra is not in the same area as the caudate, the putamen, and the globus pallidus, right? But here you can see where it exists in the midbrain. They all find a way to communicate though, even though they're not exactly in the same area. So here's another cross-section image of the brain. This image is exactly what I was trying to refer to. an image like this where it's anterior to posterior. You can see the pathways a little bit. You can see where the thalamus is. However, again, keep in mind that this structure, the basal ganglia, is a three-dimensional structure. It's not a two-dimensional structure in which cross-sections always kind of suggest. So just keep those things in mind, okay? But let's take a look and see where each structure really is. So the striatum and the lenticular nucleus, which you can see on the table on the bottom left, okay? These are just combinations of the caudate, the putamen, and the globus pallidus. These are deep within the hemispheres. The substantia nigra is in the brainstem. The subthalamic nucleus is ventral or anterior to the thalamus. And we haven't talked about it yet, but you can see the orange and blue lines. These are how they all communicate with each other, along with the rest of the cortex and the thalamus. So now that we have seen pictures of the basal ganglia, let's talk about what they actually are and what it does, okay? So the basal ganglia is a collection of gray matter. Yes, that is deep within the brain. Gray matter means that this is an area of cell bodies. So think about of the neurons, right? Cell bodies of the neurons. These cell bodies are then going to turn into the axons, which are white matter, and they're going to travel to different areas. White matter checks have to be present because this is how you communicate information. However, gray matter, basal ganglia, that is where the cell bodies are located. So the basal ganglia are involved with the planning, the initiation, and the execution of movement. So just think about this. Isn't this the exact problem of what people who have Parkinson's disease are going through? The planning, the initiation, and the execution of movement. People with Parkinson's disease, they're rigid, they can't move, they have small movements, they have a hard time initiating movement. So think about shuffling gait. This is all that has to do with planning, initiating, and executing a movement, right? So these are the main things that we normally associate with the basal ganglia with its relation to Parkinson's disease. However, there are more functions of the basal ganglia, and this includes controlling our posture, maintaining our muscle tone, producing automatic movements. So these are also things that we're going to see that are impaired with people who have Parkinson's disease. Furthermore, the basal ganglia is the integration center for the cortex. And what this means is that the cortex is going to communicate with the basal ganglia. Then the basal ganglia is going to process this information that the cortex just gave. The basal ganglia will then send information to the thalamus, then back to the cortex. So a lot of communication, okay? The basal ganglia has even more functions. And this can include things like with cognition, things to do with the reward system, executive decision making. So once again, everything that the basal ganglia does are things that will also be impaired for people who have Parkinson's disease. So just think about, again, dual tasking. Cognition is affected. Here's a little schematic about the relationship that I've been talking about regarding communication between the cortex, the thalamus, and the basal ganglia. So as you can see from this table, there's information that's being sent from the cortex to the basal ganglia. Then there's also information being sent from the basal ganglia to the thalamus, then to the cortex. So let's take a little bit more of a look into what kind of information is being sent to and from. So the chart shows that there is a motor channel. So think about movement of our body in general, upper extremity, lower extremity, trunk, everything, right? There's also an ocular motor channel, meaning our eye movement. There's a prefrontal channel. Well, what does the prefrontal cortex do? It is the area for executive decision making, personality, reasoning. Aren't these also the things that I mentioned earlier that are impaired with Parkinson's disease? Even though the basal ganglia does not technically directly affect these kind of things, it is definitely communicating with the area that does, and that is why it is affected. Furthermore, there's also a limbic channel connection. The limbic system includes the amygdala and the hippocampus. What do these things do? Well, they regulate emotions, memory, learning. Again, things that we have mentioned already. The basal ganglia is not technically the source of why these impairments are occurring. However, once again, it does communicate with the area that is causing these impairments. So, what is the pathophysiology of Parkinson's disease? Even though I've been talking about the basal ganglia as a whole is not the reason for why Parkinson's disease occurs. Parkinson's disease occurs specifically because of a fault in one component of the basal ganglia. I've mentioned it before. It occurs at the level of the substantia nigra. The substantia nigra does not produce enough dopamine in this case. And I'm going to show you in the upcoming slides, but dopamine is a huge factor of why we are not able to communicate effectively between the cortex, the thalamus, and the basal ganglia as it normally should. The communication is done through the two pathways called the direct pathway and the indirect pathway. All right, it is finally time to talk about the pathways, the direct pathway, the indirect pathway. These both work together to facilitate movement. The direct pathway is excitatory, meaning that if it's stimulated, movement will happen. The indirect pathway is inhibitory, meaning that if it's stimulated, movement will not happen. This occurrence is normal. It should work like this. Now, when you look at this chart and you compare the two pathways, you can see that almost all the steps are the same with respect to what communicates with what, right? However, you can see that there is a little section within the direct pathway where there is an extra couple steps, right? We go to the globus pallidus, the subthalamic nucleus. Those are also involved. But just to keep it simple, you can see that pretty much both pathways, the striatum, which is the putamen and the caudate combined, they receive information from both the cortex and the substantia nigra. Again, we've talked about the substantia nigra. Its job should be to produce dopamine. So the substantia nigra is going to send the dopamine to the striatum. The cortex is going to send glutamate, which is an excitatory neurotransmitter, to the striatum. Now, through both the direct and indirect pathways, information continues on through the basal ganglia until it eventually communicates with the thalamus, which then communicates with the cortex. Again, direct pathway, it's excitatory, mean yes, I want to elicit a movement. The indirect pathway, if it's activated, means that no, I do not want to elicit a movement. I want to inhibit it. Both of these pathways are important. They have to work together to make movements occur the way that we want them to. Now, something that I want to clear up for those who might be a little bit confused, because I get that I was confused as well. I want you to look at the bottom of the flow chart where it shows that communication from the thalamus to the cortex. So you're going to see that both the indirect and direct pathways show that glutamate is being sent from the thalamus to the cortex, which in theory you would think, well, doesn't that mean you're exciting the cortex, right? So why are both being excited if I'm telling you that one is excitatory, one is inhibitory? Well, I think the direct pathway makes sense because, yeah, again, you're trying to excite it. But with the indirect pathway, what's actually happening is that even though glutamate is being sent from the thalamus to the cortex, this does not mean that you're exciting the cortex to elicit a movement. What you're exciting to the cortex is to promote, yes, I want inhibition. You're telling the cortex, correct, I do not want movement. Okay, so we're going to get into the pathophysiology of it, all right? What I want you to understand is that with the direct pathway and with the indirect pathway, you can see throughout everything is functioning normally, okay? The pathway itself is not damaged. There's no fault with the structures. The problem with Parkinson's disease, though, is, again, the dopamine levels. The substantia nigra is unable to produce enough dopamine for it to be sent at an optimal level into these pathways, right? If you're not able to produce enough, or maybe not at all, depending on how extreme the Parkinson's disease is, well, there's not going to be enough inputs to continue on the message throughout this pathway. The pathway needs a certain level of dopamine to be present to continue with the transference of information. So to give an analogy, and this is just something that I thought about myself, think about the cortex as or when it produces and sends glutamate, think about this as the first part of a sentence, and the dopamine that's being sent from the substantia nigra as being the second part of a sentence. So let's say that when it is working normally, I'm telling the thalamus and eventually the cortex that I want to lift my right arm. Now, when dopamine is not working, the second part of the sentence is going to fade out and it's going to sound like this. I want to. Or, if anything, if it's not completely shut off, it is going to sound a little quieter, right? I want to move my right arm. So the information is not being sent as strong or as well communicated as it could be. So trying to excite the direct pathway to initiate movement and execute movement is not like it was. Same thing with the indirect pathway. The information to tell the brain and thus the body to stop a movement doesn't work as well. Well, apply what we are talking about to what we see in Parkinson's disease. No dopamine means no communication through the basal ganglia to tell the cortex to perform a movement. Thus, no movement, or at least decreased movement. Isn't that exactly what we see with Parkinson's disease? Think about this slide as kind of a summary. We've kind of covered everything, right? What is Parkinson's disease? It is a problem with the amount of dopamine levels that are circulating the brain. Unfortunately, Parkinson's disease is progressive. It's degenerative. So you will have to educate your patients. You're going to have to educate their loved ones that it will, unfortunately, get worse. Of course, the rate and the intensity of how this progresses will depend on each person, as with all things. As a physical therapist, knowing this scale, the Hone and Yar scale, I'm going to say is really, really important for you to know because it actually allows you to communicate with others within the medical profession about their stage and the expectations of what they have for their patient. Remember, it's a progressive disease, so you're not going to expect regression necessarily, but you can kind of see through the scale what might be the next thing to expect your patient to present like. All right, so we know what Parkinson's disease is. We know the pathogenesis. Now, let's talk about treatments. With Parkinson's disease, you cannot be, as a physical therapist, the only provider. These patients absolutely need to have medications, and they have to see a neurologist. The drug that you should absolutely know, like I've mentioned before, is the one that you should absolutely associate with Parkinson's disease, is levodopa. Levodopa, aka carbidopa. These are both the generic drug name, while Sinemet is the brand name. So you can think about, Advil versus ibuprofen. This drug, when you ingest it, is converted within our neurons to make dopamine. So if dopamine is the problem, why don't we take a drug that increases our dopamine levels, right? So this is the most effective drug used to treat Parkinson's disease. Now, once again, Parkinson's disease is progressive, so taking this drug is not going to stop its progression, unfortunately. However, it can at least provide enough dopamine at a certain level to replenish the ones that are lost. So dopamine levels made from the body will continue to decrease as time goes on. That is the natural course of this disease, but you can take more and more and more of this drug to ideally compensate for that. It will not stop, as in the drug is not going to stop the disease progression, but it can at least substitute for it in a sense. Now, at a certain point, as much as you take this drug, it is going to result in motor complications still. And if anything, it can result in motor complications that result in things like dystonias, dyskinesias. All these are involuntary postures and movements. Furthermore, you should be aware of the situation called the on and off phenomenon, where even though your patient is taking levodopa, for some reason, the drug is not able to be so effective, and just like a light switch, the Parkinsonian symptoms come right back. It's just a complication that we have to almost expect from taking this drug, especially if you're taking it chronically. Okay, so it's, you have to educate your patient and their loved ones that these things can happen and it's spontaneous. So that's where, they'll have to talk to their neurologist about how to manage it when this comes up, if it's a dosage thing or if it's changing the timing of when they need to take it. Now, I added side effects because if this person is going to take this drug on a regular basis, you as a physical therapist have to know what to expect. And the reason why you want to know is because you don't necessarily have to be fearful when these side effects occur. So let's say you're treating someone who has Parkinson's disease and all of a sudden they feel nauseous or dizzy. Now, let's say if you're treating a person who doesn't have Parkinson's disease and all of a sudden these signs and symptoms are presenting, for me, I'd personally get a little scared. Like, oh, okay, well, this person might be having a heart attack, or what's going on with their blood pressure? Do I need to call a code? And, you're probably going to sit them down, check their vitals and all these things. However, if you know the side effects that could potentially happen from taking this particular drug, it can maybe calm you a little bit and say, oh, this is actually expected. I already understand that this could be a potential. Of course, you should do your due diligence and take their vitals anyways, just to make sure, but it is, some good knowledge to keep in your back pocket. All right, now another treatment that can be done with those who have Parkinson's disease is deep brain stimulation. So electrodes are placed on the side of your patient's brain to essentially zap the brain to promote more dopamine release. The mechanism, and I really did try to look this up, it's still to be researched though, it remains unclear. And if anything, at the end of this lecture, I will provide some information for if you want to look into the article that I was looking into that talks about it. All right, our bread and butter, treatments from physical therapists. Obviously, now this is within the scope of our practice. There is an optimal way of treating people who have Parkinson's disease, and it's not your generic, well, they're unable to reach far. Is it a range of motion thing? Which, yes, it potentially could be. However, it is different. So, with Parkinson's disease, you should associate big and loud. High amplitude, large movements are what we want to do with these patients, high intensity. People with Parkinson's disease have difficulty with initiating and executing their movements, right? If we force these patients to make large movements consistently and repeat and repeat and repeat and repeat, etc., the idea is that you're going to be able to change their brain, neuroplasticity, to be able to continue performing these movements. So you're not necessarily increasing the level of dopamine that's present and being produced and circulated, but the rewiring of the brain to create this larger, higher intensity movements that ultimately create a normal movement, so they're not just exploding a little bit extra. Doing this consistently is essentially what you want to do for those people who have Parkinson's disease. What I need you to understand too is that speed is not a criteria for this. It is not how fast a person can walk, not how fast they can reach for a mug or anything like that. It's the ability just to perform that movement at the optimal intensity, at the optimal length of reaching, of walking, step length, things like that. Adding speed could be utilized as a challenge if that person is successful at grabbing that mug or walking. However, it's not the thing that you should initiate with. The famous LSVT, big and loud, is the concept of large movements. It really does work. I got my own certification in it, so I've tested it out, and these things, people are smart researchers are doing all this work. Why not take their work and utilize it, right? Now, as for other treatments, I've listed them here, walking on varied surfaces, virtual reality, reactive balance, anticipatory balance. I mean, even without associating these directly with Parkinson's disease, aren't these all kind of things that you should be considering for any and all populations that you treat? Just because a person has Parkinson's disease doesn't mean you need to take out your handy dandy notebook and say, oh, I should work on reactive balance with them, right? I mean, if a person has challenge with reactive balance or anticipatory balance, these are impairments. As physical therapists, we find impairments and then we are going to address it, right? Whatever impairment you see, you're going to treat it. Next up, dual tasking is specific to Parkinson's disease. We've talked about how Parkinson's disease, basal ganglia, affects the cognitive state. It requires a lot of energy and a lot of attention to do one thing, such as movement. But with Parkinson's disease, when you have multiple things going on that make it harder to pay attention to those movements, or at least effectively perform those movements, it's going to be way harder for them to do two things at once, right? Rock steady, virtual reality. These are kind of unique to Parkinson's disease, but they are, if anything, kind of just another way to incorporate what we've already talked about. Virtual reality, hopefully the source that they're using incorporates high amplitude, high intensity movements. Rock steady, it's a type of boxing that can be done with people who have Parkinson's disease. This boxing, it's going to include large amplitude, high intensity arm movements. So once again, they incorporate the same idea, which is really a good thing, but it is nice to have some sort of ability to have a unique aspect to it, a different option that these patients could have versus just performing one treatment, right? I mean, it's kind of fun punching something, right? Clearly, that was a lot of information, but hopefully this lecture clears up some things about what is most important to know about Parkinson's disease. Of course, there are so many things extra that you can understand about this. However, just to have in your back pocket, I think understanding these things will really help you out. When you're studying for the NPTE, check out our courses at sptwithme.com. If you're interested about looking at the article that I mentioned previously about the deep brain stimulation and its effect on dopamine levels, the mechanism of how it occurs, that's the one that's in the middle.